So I'm James Galbraith. I'm an emergency provider at UAB. Over the last decade, I've served on the front lines of our intensifying opioid epidemic, not only serving as a rescuer for individuals who have overdosed secondary to opiates, but also as a safety net provider that's often under-recognized for patients with opioid addiction who are presenting with varying complaints, seeking care for addiction, for psychiatric complaints, trauma complaints like motor vehicle accidents, and also infections that include soft tissue infections, bloodstream infections, and my particular interest is in blood-borne virus infections like hepatitis C and HIV. So here I'm going to talk about our emerging hepatitis C epidemic in Alabama amongst injection drug users, as well as the real vulnerability for an outbreak of HIV in our community amongst users. To frame this presentation, it's not just an opioid epidemic. We have really a syndemic of opioid misuse and addiction that's in associated needle use that's driving another epidemic, which is our hepatitis C epidemic, as I mentioned earlier. And that's related to needle scarcity in our communities and the practice of needle sharing. Most of you are familiar with HIV infection, so I just wanted to take a few moments to give you some background about hepatitis C infection. Hepatitis C is a blood-borne virus. It's highly prevalent in the United States. About 5 million persons in the US carry chronically hepatitis C infection. It has a high morbidity and mortality. So what does that mean? Well, there's injury that occurs secondary to the virus. Up to 20% of individuals that have hepatitis C will develop cirrhosis of the liver, and 1 in 20 will ultimately die of liver cancer or liver failure if it's untreated. It's also our leading cause of transplant, and hepatitis C, as of 2007, has a higher death rate in the United States than HIV infection. And this is alarming because we now have a cure for hepatitis C infection. That's a 12-week course of all oral medications. In the United States, who has hepatitis C? What populations? Well, not to offend anybody here, but it's largely a disease that has affected the baby boomer population that's born between 1945 and 1965, who account for about 3/4 of the infections. Largely, hepatitis C was acquired through medical procedures like blood transfusions before we actually had a test or knowledge of what hepatitis C virus was. But today, since 1992, since we've had testing for hepatitis C and are able to identify it, 25% of our patients with hepatitis C are actually in a younger cohort. Largely, it's a white cohort under the age of 30, and the numbers of those living with hepatitis C now is on the rise secondary to injection drug use. In some of the Appalachian states, this study didn't include Alabama, we've seen a continued rise over the last decade of the number of hepatitis C infections related to injection drug use, particularly in Kentucky, Tennessee, Virginia, and West Virginia, with a disproportionately high burden of hepatitis C in the non-metropolitan areas or rural areas. Our emergency department in 2013, I implemented hepatitis C screening. So we now had a cure available, so I wanted to identify the majority of individuals infected. So I began offering targeted hepatitis C screening in our emergency department, and largely what we ended up testing was baby boomers. Of baby boomers that were tested that had previously stated they did not have hepatitis C infection, we were diagnosing the infection in 1 out of every 9 individuals coming to our department. Even though that prevalence was high at 11%, we still recognized that we were missing a really vulnerable population and growing population of persons who inject drugs, and we simply weren't testing enough. So in September 2015, I went to a non-risk-based universal screening strategy where we no longer asked about any risk factors before providing hepatitis C testing. Today, if you came to our emergency department, if you were medically and surgically stable and over the age of 18, we'd let you know that a test would be performed unless you wish to decline or unless you already knew you had hepatitis C infection. Alarming, what we found was not the continued high rate amongst baby boomers, but particularly in our younger population born after 1965, we're identifying an overall prevalence of 6%. But when you break it down by race, what we're seeing is elevated prevalence amongst younger white individuals. 1 out of 8 white individuals born after 1965 visiting our emergency department is testing positive for hepatitis C infection. And what I can tell you is based on the epidemiology of hepatitis C infection, this is largely driven up to 90% secondary to injection drug use. But hepatitis C is curable, and so We can identify these individuals and guide them into care. It's a lengthy process, but we do that for everybody we diagnose, and we have over 3,000 people in 3 years that we've identified in our emergency department. But the real risk is also as easily as you can acquire hepatitis C infection, I should say almost as easily, you can acquire HIV infection through unsterile needle use or needle sharing. And we saw this happen in Scott County, Indiana in 2015. So in Scott County, in a small community of about 4,000 individuals, in a 1-year period of time, over 140 cases of HIV infection were identified in a small community of injection drug users who were using the drug Opana and injecting. In response to this, and the question arose like, well, what other counties or communities are vulnerable to a similar outbreak for HIV amongst injection drug users? The CDC did a vulnerability study. Without belaboring the details of the study, essentially they looked at factors associated with new cases or acute cases of hepatitis C in the United States and came up with a vulnerability score for counties that they thought were at risk for HIV or hepatitis C outbreaks in the United States. On this map is the top 5%. And so the top 5% most vulnerable, you can see the clusters all around Appalachia, and that does include Central Alabama as well. Now, this is not an all-inclusive list. This is just with the best available data that we have. So let's look a little bit more granularly at Alabama, just based on that vulnerability report. We had 4 counties that were identified, one of which was Walker County. Walker County, in that vulnerability score, ranked 37. For perspective, Scott County, Indiana, ranked 32. They had an HIV outbreak. So the risks are there, and the recipe is very similar to what happened in Scott County, Indiana. What we want to know, though, too, is how much injection drug use and opioid misuse is occurring. And I'll talk about this a little bit more later, but we don't have very good data sources other than deaths and arrests. What I was able to pull was EMS naloxone administration data, and you can see that the darker it is, the more prevalent in a county that you're seeing more naloxone administration events by EMS per 10,000 people. And Walker County lit up, but so did Jefferson County and Coleman and Bibb and on. But Walker County had one of the greatest risks. So I took our emergency department data for younger individuals that were diagnosed with hepatitis C infection, and then we looked at where is the infection being clustered. What were the outlying zip codes where we're seeing hepatitis C prevalence rates beyond what we would expect in some of the surrounding areas? And what we're able to identify is that there are several zip codes that were at risk, but they run right along the border of Jefferson County and Walker County itself. And the concern here is that if we think there's active hepatitis C transmission occurring along that border amongst injectors, there's also a risk of HIV transmission as well. I should remind you that Jefferson County is a highly prevalent HIV county with about 1 out of every 240 persons in Jefferson County living with HIV infection. So the recipe is there and the risk is there for an outbreak of HIV as well. That doesn't mean these are the only places that it could happen. It just means with the available data we have, this would be one spot. So to change course a little bit, obviously our real goals in curbing this syndemic are let's get everybody into addiction recovery or abstinence. But these abstinence policies alone have really failed us over the last 30 years. But we do need to increase access to addiction services and care. But that's going to take some time and it's going to take a lot of money. But there are things that we can do immediately now to reduce the number of deaths and reduce the spread of bloodborne infections, and things that have been done for 30 years in the United States and overseas. And we're going to talk a little bit about harm reduction. So what is harm reduction? It's just basically a set of strategies and ideas aimed at reducing the negative consequences of injection drug use. So interventions that we've talked about already today: home naloxone distribution, opioid replacement therapy or medication-assisted therapy, syringe service programs, or otherwise known as needle exchanges, which I'll talk about momentarily, and expanded bloodborne virus testing. But with these types of interventions, we can reduce the number of overdose deaths we see. We can reduce the spread of bloodborne virus infections. We can test, we can refer individuals for treatment, we can vaccinate individuals. We can educate users on safer practices, and we can reduce illicit use and more dangerous use through opioid replacement therapy. And most important in a harm reduction strategy is just the engagement of a vulnerable person who has nowhere else to go. And I see this every day in our emergency department, and we're failing them. So what is a syringe service program? I only have one slide about this because this is a controversial topic. Well, it's not just about needles, and it's not just about the exchange of needles. Certainly a syringe service program provides clean needles and accepts clean needles for disposal. But syringe service programs also engage the user. They provide mental health referral, addiction referral to medication-assisted therapy, counseling, vaccinations, and can be a site where we can get additional surveillance about how bad our problem is. Right now, it's in the shadows. I'm not an expert here on long-term treatment, but what I know and what I believe is that long-term care, whether it's inpatient, residential, outpatient, it's going to have to be affordable and it's going to have to be accessible, and that means it's going to cost money, and we're going to need money and funds from somewhere to come in to support it. And with those funds, we need to have places that are funded to be accountable for their outcomes. We need to know how places are actually doing. We have similar metrics in the healthcare setting where we're held to how heart failure patients do. I want to know how the patient with addiction is doing, and I don't think that we really have those measures to tell us what kind of quality are the services they receive. Some are going to be good, some are bad. I'm not going to belabor this because we've talked about this quite a bit, but criminal justice reform is going to be really important. I see a lot of jail patients coming into our emergency department who are going into withdrawal and need help, but they're really not receiving any addiction care. They're not receiving any medication-assisted therapy or opioid replacement therapy. And I don't think we're helping them in many ways by arresting them for a week and then putting them back on the street or in the community no better for having had the arrest in the first place. So we need to improve their medical outcomes. It'll reduce recidivism and it'll reduce costs. I'm going to run short on time, so I'm going to hurry through the rest of this, and I apologize. The current scope of our epidemic in Alabama, the biggest problem we have is that we really don't know how bad the problem actually is. We just know the tip of the iceberg, and we know it's bad just based on the number of deaths and arrests, but we have a big knowledge gap. We don't know the true size of the epidemic. How big is this iceberg? We don't know the locations of where the epidemic is worse. We have some ideas in central Alabama. We don't know the prevalence of bloodborne virus infections. And we need to know this information so we can predict the costs, locations of any of our interventions that we plan. And we also need it to serve as a baseline to measure if we do an intervention, is it even effective? So we're going to spend money on this. Let's know how bad the problem is so we can see how we shape it. Financially, the question is going to be who pays for this, and politically, the question is can we align our laws with the evidence to reduce harm in Alabama? 2 more minutes, I promise I'll be done. Funding sources. So this is a big question. I think about this a lot as a researcher, is where are we going to get money to cover this? Well, one, I'd say the Alabama General Fund. I'm not in Alabama politics, but I see this as a vote winner. Is money coming from the state to help with addiction is going to be a vote winner for many people. Most have been affected by addiction in our state, and I don't care what party you're aligned behind, it's a vote winner. For public health dollars, it's going to improve our surveillance. For the criminal justice system, $1 spent on addiction in some studies has shown a $7 reduction or cost savings in crime and imprisonment. And this has been the strategy why in the United Kingdom, all of their addiction services are largely paid for by the criminal justice system. That's where most of the money comes from. And for healthcare insurance providers, every dollar spent can save up to $4. Now that's just in one study, but the answer is health systems and insurance providers are going to have to contribute. And I'll tell you that this can't become a political issue, left versus right. We need evidence-based interventions, and I will remind many in here that Margaret Thatcher, the conservative prime minister of Britain, was the first to enact legislation for syringe exchanges in Britain against her party's wishes, and it's been heralded as a large success now. 30 years later, they're still talking about it. Other states similar to ours are paving the way to more harm reduction. That includes Indiana, Kentucky, West Virginia, where they're providing syringe services. And our barrier currently right now is a law that defines drug paraphernalia as a syringe or needle that's intended use is for injecting controlled substances. But what we need is a little exclusion to allow for the authorization of a syringe exchange by law, or an exception that allows us to distribute syringes to prevent bloodborne diseases. And I'll close on this. So Tom Frieden from the CDC, this was a quote I took off of Twitter. Your longevity and health are more determined by your zip code than your genetic code. And I see this, I do a lot of geospatial mapping of outcomes in our communities. And largely where we see bad outcomes, it's because of economics. But the challenge is we can't always change that, but we can change our policies and we can change our funding to those communities that are being negatively affected by policies that might be hurting them. So let's take what we can control and try to fix this problem. I've got my email and contact information on the next slide, and I encourage anybody who's interested in talking about this to please contact me. Okay? Thank you so much for your time.